With this, we move on to the next segment of today's scientific fiesta. And the next topic is the treatment of angina in chronic coronary syndrome. Where do you stand? And to speak on this particular topic, I would like to invite Dr. Debopam Goswami, who is a renowned specialist in cardiology, bringing several years of invaluable experience to his practice. And he's attached to Nightingale Hospital as well as BP Poddar Hospital and certain other clinics. To chair this particular session, I would like to invite Dr. BP Pandey, who is a renowned cardiologist and also founder, member and secretary of Howrah Town Diabetes Study Society. Along with him, I would like to invite Dr. Somnath Mukhopadhyay, who is an expert and experienced cardiologist from Howrah with more than 10 years of experience. Thank you, chairpersons. We welcome you on stage. Speaker, sir, over to you.
So, Debopam, start the proceeding.
Good evening, everyone. My topic of today's session is treatment of angina in chronic coronary syndrome. Now, so the outline of my talk will be based upon these following things. First of all, we'll discuss about the dynamic nature of the chronic coronary syndrome. It's a growing clinical challenge worldwide. We'll discuss about the clinical spectrum of chronic coronary syndrome, the treatment of angina, the current scenario, the empirical paradigm in selection of anti-anginal therapy, a brief discussion about the anti-anginal drugs, revascularization strategies, a brief discussion of the non-obstructive coronary artery diseases and refractory angina. Now, this definition of chronic coronary syndrome was modified in the year 2019 by the ESC, which states that CCS are a range of clinical presentations or syndromes that arise due to structural and or functional alterations related to chronic diseases of the coronary arteries and or microcirculation. These alterations can lead to transient reversible myocardial demand versus blood supply mismatch, resulting in hypoperfusion, usually provoked by exertion, emotion or other stress, and may manifest as angina, other chest discomfort or dyspnea, or may be asymptomatic. Although stable for long periods, chronic coronary diseases are frequently progressive and may destabilize any moment with the development of an ACS. Now, this is a very complex definition and we will try to break it down. So, what about the dynamic nature of the chronic coronary syndrome? Now, previously what we knew about stable coronary artery disease was that it's a fixed focal flow limiting atherosclerotic stenosis of a large or medium coronary artery that was the sine qua non for inducible myocardial ischemia and ischemic chest pain. Now, what has developed over the years is to be divided at a macro level and a micro level, and for the micro level there can be, even if the disease is not a flow limiting fixed disease, it can be a diffuse disease. There can be presence of myocardial bridging, coronary anomalies, dynamic epicardial vasospasm at the macro level, and at the micro level there can be microvascular dysfunction and non-obstructive coronary artery disease. So these all comprise a chronic coronary syndrome. Now, this is again the classification based on the epicardial and the microvascular sections. Now, the clinical spectrum of chronic coronary syndrome, they can present in 5 patterns. First can be asymptomatic with abnormal coronary anatomical or functional test. Second, there can be angina or equivalent with no obstructive coronary artery disease. Third, there can be stress-induced angina or equivalent with obstructive coronary artery disease. And fourth, there can be a stabilized phase after ACS, PCI or CABG. And the fifth can be LV dysfunction or heart failure of ischemic origin. So these are the 5 clinical spectrum of chronic coronary syndrome. Now, angina pectoris, 10 to 25% of patients with suspected chronic coronary syndrome, they present with angina. Anginal chest pain is equally prevalent in both men and women, and a third of patients have suboptimal treatment regarding lifestyle modification and appropriate use of anti-anginal drugs. Now, this is again the symptom characteristics. We already know about what are the symptom characteristics which are likelihood of CCS. Now, this is a study, the Clarify population of 32,703 patients with chronic coronary syndrome. So, the patients, these were basically, it was a prospective study, and the 4 classes were usually present in this study. First were the patients who had revascularization in less than 3 months. Then there were patients who had history of an ACS within 3 months, and patients also having inducible myocardial ischemia, they were included in the study. So what was found was that the angina was associated with poor prognosis in patients without prior MI. And patients with prior MI and angina symptoms, they represent 14% of the chronic coronary syndrome population and are at highest risk. And patients with both angina and prior MI are an easily identifiable high risk group which may deserve more intensive treatment. So not only having angina is important, but angina in a patient with prior MI, they have the highest incidence of primary outcome than without prior MI. Now this is an old chart with respect to angina, that is basically a mismatch between the oxygen supply and the oxygen demand. Now for the treatment of angina, the current scenario, the goal is to control the symptoms. There are a lot of challenges in the selection of anti-anginal therapy because of lack of robust evidence, need for combinational anti-ischemic drugs, and there are different pathomechanisms. Now when we come to the choice of the initial therapy, now optimal therapy can be defined as the treatment that satisfactorily controls symptoms and prevents cardiac events associated with chronic coronary syndrome with maximal patient adherence and minimal adverse effects. That is called optimal treatment. Now the selection of this initial therapy, it should be based on an individualized approach that considers other cardiovascular conditions like hypertension, tachyarrhythmia, conduction system disease, peripheral arterial disease, and LV dysfunction. Rather, comparative studies of anti-anginal agents have not shown any meaningful difference in efficacy to differentiate one specific class of agents from another for patients with symptomatic ischemic heart disease and no previous MI. Rather, selection of the optimal agent is usually based on overall consideration of the management of coexisting conditions, tolerability, and cost. And for all practical purposes, beta blockers or calcium channel antagonists, which are effective and low cost, they remain the first line of therapy. Now, so the combinational therapy, when we choose a combinational therapy, we have to think of, we have to base it upon individualized approach, hemodynamic profile of the patient, comorbidity, and tolerability. So what are the available drugs? Now when we think of the available drugs, we have beta blockers, the calcium channel blockers, which can be the non-dihydropyridine calcium channel blockers, and the DHP calcium channel blockers, ivabradine, and the newer drugs like nicorandil, ranolazine, and trimetazidine. Now among these, the beta blockers, the non-DHP calcium channel blockers, and ivabradine, they more or less take care of the oxygen requirements, that is, they reduce the oxygen demand. And the nitrates and the DHP calcium channel blockers, they are more concerned with the increasing of the oxygen supply. Now we first come to the beta blockers. Now the beta blocker, as we already know, they reduce the heart rate at rest and during exercise, and reduce the myocardial contractility and blood pressure, and thereby they reduce the oxygen demand and burden of the myocardial ischemia. Now we will discuss about these different patient profiles that we can use beta blockers in our later slide. Now when we come to nitrates, they release nitric oxide. Now there will be lots of sources like isosorbide. They can be they are present in many forms like mononitrate, dinitrate, and nitroglycerin. The basic mechanism is when they enter into the cell, they release this nitric oxide, which activates the guanylyl cyclase, which converts GTP to cyclic GMP, and that causes the vasodilation. So that vasodilation is an important mechanism, and at low doses they are venodilators, preferential venodilators, and at high doses they are peripheral coronary artery dilatation. So in a nutshell, they reduce both the preload and the afterload. Now when we come to the calcium channel blockers, they have divided into the DHP and the non-DHP. So what do? They inhibit the calcium influx in the smooth muscles of the arterial wall. That reduces the cardiac afterload and the oxygen need, and improve the oxygen delivery by improving the coronary dilatation. So that again has this anti-ischemic effect. Now we will discuss about the profiles for calcium channel blocker use as well. Now the other drugs will be the nicorandil and trimetazidine. Nicorandil is a nitrate derivative of nicotinamide and adenosine sensitive potassium channel opener with nitric oxide donor capacity. It dilates the coronary arteries. And trimetazidine, it increases the anaerobic glucose metabolism, reduces the free fatty acid oxidation, and increases the cellular tolerance to ischemia. Now, trimetazidine, it does not exert hemodynamic effects, and it is contraindicated in Parkinson's disease and motion disorders such as tremor, muscle rigidity, walking disorders, and restless leg syndrome. Now, coming to ranolazine. Now, this ranolazine was tested in a lot of trials like the CADISA, ERICA, and the Merlin-TIMI 36, but all trials have failed to show any cardiovascular mortality benefit, but they definitely reduce the angina. So, the mechanism of action is it causes a concentration, voltage, and frequency dependent inhibition of the late sodium current, prevention of the intracellular calcium overload during ischemia, and also distribution of the myocardial blood flow towards the ischemic areas with a reduction of ischemia. Now, this was a chart which has been given in the ESC 2019 guidelines, which says that the standard therapy, the first step is a beta blocker or a calcium channel blocker. When the second step is we combine both of these, and the third step is adding a second line drug like nicorandil, ranolazine, or trimetazidine. If the patient has a high heart rate, that is more than 80 beats per minute, then beta blocker or a non-dihydropyridine calcium channel blocker is the first step. Second step is again a combination of the two drugs, and third step is a beta blocker plus ivabradine. If the patient has a low heart rate, we start off with a dihydropyridine calcium channel blockers. For the second step, we switch to a long-acting nitrate, and for the third step, we add a long-acting nitrate to a dihydropyridine calcium channel blockers, and for the fourth step, we can add the second line drugs. If the patient has LV dysfunction or heart failure, we start off with a beta blocker. Second step, we add a beta blocker with a long-acting nitrate or a beta blocker with ivabradine, because heart rate control is important. And for the third step, we add another second line drug. If the patient has a low blood pressure, which is quite prevalent in our country, the first step is a low dose. Whatever drug we are giving, we will be giving in a low dose. So, a low dose beta blocker or low dose non-dihydropyridine calcium channel blockers. For the second step, we switch to ivabradine, ranolazine, or trimetazidine, because these drugs have less effect on the blood pressure or the hemodynamic profile. And for the third step, we combine all the second line drugs. Now, this is a new chart or a new diagram which has been given in the ESC 2024 guidelines, which has all the drugs, the beta blockers, the dihydropyridine calcium channel blockers, the non-DHP calcium channel blockers, trimetazidine, ranolazine, ivabradine, and nitrates and nicorandil. And the green lines which have shown are the usual combinations which are usually used. Like we use a combination of a dihydropyridine calcium channel blocker and a beta blocker, because they negate the reflex tachycardia of the DHP CCB is negated by beta blocker. The same goes with beta blocker and a nitrate. So, and the only combination they have said is not to be used is a combination of diltiazem, verapamil, and ivabradine. So, when we discuss about each of these drugs, like beta blockers, the usual indications are the ones which are highlighted in blue, that is obstructive coronary artery disease, microvascular dysfunction, arterial hypertension, atrial fibrillation, and HFrEF. To be used with a bit of caution, the beta blockers are to be used with caution in COPD patients, patients of peripheral arterial disease, type 1 diabetes, and diseases where they are contraindicated is a 6 sinus syndrome. Same goes with diltiazem and verapamil. Now, for nicorandil and nitrates, the usual indications are obstructive coronary artery disease and vasospastic angina, and they are contraindicated in HCM. For ivabradine, again, the usual indications is a HFrEF, and they are contraindicated in case of 6 sinus syndrome. For trimetazidine and ranolazine, these are used in case of obstructive coronary artery disease and also microvascular dysfunction. Now, these are the recommendations as per the ESC guidelines. So, short-acting nitrates are recommended, that's a class 1 recommendation. Initial treatment with beta blockers and calcium channel blockers, that is again a class 1. If anginal symptoms are not successfully controlled by initial treatment with a beta blocker or a calcium channel blocker, the combination of both should be considered unless contraindicated, that is a class 2A. Long-acting nitrates or ranolazine should be considered as add-on therapy in patients with inadequate control of symptoms while on treatment with beta blockers and or calcium channel blockers. That is again a class 2A indication. When long-acting nitrates are prescribed, a nitrate-free or low nitrate interval should be considered to reduce tolerance. Ivabradine should be considered as add-on anti-anginal therapy in patients with left ventricular dysfunction, that is EF less than 40%, and inadequate control of symptoms, or as part of initial treatment in properly selected patients. Now, 3 points important. Ivabradine is not recommended as add-on therapy in patients with chronic coronary syndrome with EF more than 40% and no clinical heart failure. And combination of ivabradine with a non-DHP calcium channel blocker or other strong CYP3A4 inhibitors is not recommended. Nitrates are not recommended in patients of HCM. Now, revascularization. Now, when we discuss about revascularization in chronic coronary artery disease, we think of basically the mechanism of the presentation of a coronary artery disease can be inducible ischemia, where the invasive treatment aims at restoring the coronary flow capability. There can be ischemia at rest, which can be chronic or acute. The invasive treatment which is required here, the mechanism is reperfusion. And for the risk of infarction, is the coronary artery disease can also present like that, and the invasive treatment mechanism is prevention of infarction. Now, to test this, the first trial that was done was the ischemia trial. The research question was, does invasive strategy improve outcome in chronic coronary artery disease if ischemia is detected? Definitely the answer was, there will be symptomatic relief, but when we looked at the cardiovascular mortality and the all-cause death, the primary outcome, there was no improvement in mortality. Now, next, another question, the next arm which we will discuss is the chronic ischemia, that is patients with EF which is less than 35%, and for this we look at the STITCH trial. To answer this, the question whether CABG improves outcome in chronic coronary artery disease with EF less than 35%. Now, what was seen was that there was definitely the CABG prolongs life in patients with ischemic heart failure. There was on 10 years follow-up of this study, there was seen that patients who underwent coronary artery bypass graft, they had 18 months more survival than patients who were put on OMT. So the same thing was tried for, and what was important in this STITCH trial was the CABG treatment was independent of the viability and presence of inducible ischemia. Now, the same thing was tried for the PCI. The trial was the revived BCIS 2 trial, but unfortunately this trial showed that there was no mortality benefit, although there was some symptomatic relief for the patients. So there are a lot of debate why this difference between the STITCH and the revived took place, but some of the points may be that the revived trial patients were on an average 10 years older. They had less frequent history of MI and were more likely to be angina free at baseline, and they included fewer patients with 3 vessel disease. And additionally, the STITCH trial was performed in from 2002 to 7, and the revived BCIS was performed much later. So the patients received much more modern heart failure therapy and were more commonly treated with ICD or CRT. Now, to summarize the revascularization strategy, to improve symptoms, definitely revascularization is a class 1 recommendation. Now, to improve outcome, if the ejection fraction is more than 35%, if the patient has LMCA disease, then CABG over OMT is a class 1 recommendation. CABG over PCI is also a class 1 recommendation, and if the syntax is less than 22, then PCI can be considered. EF more than 35%, 3 vessel disease, if the patient has diabetes, CABG over OMT, class 1 recommendation. CABG over PCI, class 1 recommendation. PCI gets a class 2A recommendation. If the patient has EF more than 35%, 3 vessel disease without type 2 diabetes, CABG or PCI both can be done. If the patient has EF less than 35%, definitely CABG has to be done. And for one or two vessel disease involving proximal LAD, again CABG or PCI can be done. Now, another subset of patients with, which present as chronic coronary syndrome are the patients which have non-obstructive coronary arteries. So, a large proportion of patients undergoing coronary angiography because of angina, they do not have obstructive epicardial coronary arteries, that's called ANOCA. There are 6 endotypes: the endothelial dysfunction, impaired vasodilation, epicardial vasospastic angina, microvascular vasospastic angina, endotype combinations, and the equivocal response. Now, they can present with microvascular angina or epicardial vasospastic angina, and for the treatment we usually go for beta blockers, calcium channel blockers, ranolazine, trimetazidine, and ivabradine. And for if there are abnormalities of vasoconstriction at the microvascular level, we can use CCB or nitrates, and for epicardial we can go for CCB, nitrates, or nicorandil. Now, what is refractory angina? So, that is defined as long lasting symptoms, that is more than 3 months, due to established reversible ischemia in the presence of obstructive coronary artery disease, which cannot be controlled by escalating the medical therapy with additional anti-anginal drugs, bypass grafting, or PCI including recanalization of CTOs, or it can be due to ANOCA or INOCA. Now, so these are the modern devices that have come up. The first one is a coronary sinus reducer. Now, this complete system for the coronary sinus reducer, it comprises of a metal mesh device that is pre-mounted on a balloon catheter and is shaped like an hourglass when expanded. After the device is implanted in the coronary sinus, local flow disruption and vascular reaction lead to a hyperplastic response in the vessel wall with occlusion of fenestrations in the metal mesh. The central orifice of the device remains patent and becomes the sole path for blood flow through the coronary sinus, leading to the development of an upstream pressure gradient that results in redistribution of blood flow from the less ischemic epicardium to the ischemic epicardium. Now, another is the transmyocardial laser revascularization. Now, in this case, is performed in the operating room or the cath lab by percutaneous approach with a specialized either carbon dioxide or a laser catheter, and the laser, it interjects a strong energy pulse into the left ventricle, vaporizing the ventricular muscle and creating a transmural channel with a 1 millimeter diameter. Initial studies were promising, but because of the iatrogenic complications like ventricular perforation, cardiac tamponade, stroke, and MI, the use of this strategy is infrequent. The third is the enhanced external counter pulsation. Now, in this case, compressed air induced pressure to the lower extremities that is synchronized with the cardiac cycle is used. Specifically in early diastole, the positive pressure is applied sequentially from the lower legs to the lower and upper thighs for the facilitation of increased retrograde aortic blood flow and increased coronary diastolic perfusion pressure in patients with refractory angina. External counter pulsation, around 35 hours of treatment time, is associated with a reduction in angina frequency and nitrate use, increased exercise tolerance, and improved quality of life. Another is the chelation therapy, that is sodium ethylene diamine tetraacetic acid. So, it has the capacity to bind di or trivalent cations, including some implicated in the pathobiology of atherosclerotic coronary artery disease such as calcium. And this TACT trial was performed where 40 infusions of this mixture was given in patients. The fifth is a spinal cord stimulation, which is an option for patients with refractory angina, where the spinal cord stimulation is done using a specially designed electrode inserted into the epidural space. The beneficial effects of the neuromodulation on pain via this technique are based on the gate theory, in which the stimulation of axons in the spinal cord that do not transmit pain to the brain will reduce input to the brain from axons that do transmit pain. So, for the recommendations for recurrent or refractory angina, in patients with refractory angina leading to poor quality of life and with documented or suspected ANOCA or INOCA, invasive coronary functional testing is recommended to define the various endotypes, and a class 2B recommendation is given to a reducer device for coronary sinus constriction that may be considered to improve symptoms in experienced centers. So, the key takeaways are that the angina remains a major concern and a remarkable proportion of patients continue to be symptomatic despite traditional pharmacological therapies. In patients with CCS, anti-anginal medical therapy aims to control symptoms while ensuring acceptable tolerability and patient adherence. Among the various traditional therapies, beta blockers and calcium channel blockers, they remain the most extensively used and therefore are considered the first line agents in the guidelines. And other drugs, that is the second line drugs like ivabradine, nicorandil, ranolazine and trimetazidine, they can be added on top of these drugs as a part of the initial combination therapy in appropriately selected patients. Thank you.
Thank you. Thank you, Debopam, for exhaustive presentation. Any question from the floor? We are running short of time. Any class of recommendation for ECP in the recent guideline?
So the recent ESC guidelines have not given anything for ESCP.
No. And any guideline for antiplatelet therapy with non-obstructive coronary arteries? CCS with non-obstructive, INOCA or ENOCA? Antiplatelet.
Antiplatelets, it depends on the type of the ENOCA.
Yeah, of all the 5 endotypes, do you give antiplatelet or you don't give in non-obstructive where there is coronaries are normal?
Sir, we give antiplatelet therapies.
You give single
Yes,
antiplatelet.
yes.
Thank you. So thank you very much. We close the session here. We'd like to felicitate you.
Yes, sir.
Come forward.
I request chairpersons to kindly felicitate Dr. Debopam Goswami. I would like to invite Dr. S.K. Somani to kindly felicitate our chairpersons. Thank you, speakers, sir. Thank you, chairpersons.